Welcome to the Dr. Lexi Show. I'm Dr. Lexi, a board certified OBGYN and maternal-fetal medicine specialist, which just means a high-risk pregnancy doctor. Through my podcast, I hope to help providers as well as patients advocate for themselves to really navigate the complexities of healthcare. Today, I'm happy to introduce a very special guest who is a board certified OBGYN and certified menopause specialist. She trained at the University of Texas Medical Branch in Galveston, Texas as an OBGYN. She later completed her certification to become a certified menopause specialist. She has written two wonderful books, The Galveistston Diet as well as The New Menopause. You may have seen her on your Instagram, some form of your social media. You may have also seen her on Oprah recently. Please help me in welcoming OBGYN and menopause guru, Dr. Mary Claire Haber.
Thank you for having me.
Well, I think people are probably interested. They're like, well, I typically talk about pregnancy and also women's health, but can you kind of tell everybody a little bit about how we know each other?
So I was a resident in Galveston at University of Texas Medical Branch from 98 to 2002. And then I had a brief hiatus in Houston where I was in private practice for 3 years. But then since 2000, from 2005 to 2018, I was faculty at UTMB, and that's where we met
Yep. I
when
was
you
a
were
fellow at that
training.
time. Yeah. I
Mhm.
think people don't really know that Galveston is an island and
Mhm.
they kind of forget that. And you lived on the island. I lived on the island. A lot of fellows did not. So it was kind of fun to learn a little bit of the culture down in Galveston too.
I raised my kids there. And,
Oh, yeah.
I had one in residency, one while we were up in Houston, but then
Mhm.
my girls did all their schooling, and went to
Yeah.
high school there and everything.
Yeah. And how did you end up in this exact space of menopause? Like a little bit of the
Ooh.
journey of what got you here? Because as you and I are probably going to talk about, and we've talked about before, we got, and we love nutrition. You and I kind of had that bond of really
Mhm.
being invested into nutrition. That was my major in college. We don't get that training in medical school, residency, and as an OBGYN, that is our training. There are so many parts that we've missed along the way. So how did you end up in this space that really no one had for us in our training?
I thought I was a good menopause provider. I, took all my CMEs, checked every box. I blew the top off of my boards. I did everything that was asked of me and I mastered it. And I didn't realize until I was going through perimenopause that there were, outside of nutrition, which was huge, other significant gaps in my training. And, do I think all of women's health after reproduction ends needs to be dumped in the lap of the poor, busy OBGYN? That was my job. No.
Mhm.
And, so here I am, a generalist faculty running, I was helping to run the residency programs. I was
Mhm.
teaching medical students. I loved my job. I love my patients. I had such a great, wonderful life, but my health was changing through perimenopause, and the administrative burden of what was happening at the hospital was really taking some of the joy out of my job. It wasn't patient care, it wasn't my coworkers, not even my boss, but it was this constant drive to see more patients in less amount of time, all of the paperwork, the RVUs, like everything being, the patient record being something to document so they could bill and make money rather than a meaningful way to share, information about the patient from one clinician to another.
Mhm.
I was just getting fed up and, being held to standards that had nothing to do with care of the patient and, everything to do with can you see more in a shorter period of time. So all that was kind of swirling and happening at once. And I was getting older. I was losing my resilience to the long hours of call, to the nighttime shifts. I wasn't bouncing back. And that was due to age. And then when you pepper in menopause on top of it, where I was already having tremendous sleep issues, due to untreated menopause, something had to give. What really kind of brought things to the surface was a very cosmetic complaint. And it was happening to me and happening to my patients, and it was weight gain. I had had thin privilege for a very long time and, kind of a thoughtless, I never had food noise or never had to really think that hard about maintaining a
Mhm.
certain size. And what I'd been taught through all my training was thin was healthy. As long as you were in this certain BMI range, then you were good to go. And you didn't have to worry about being unhealthy as far as your weight. And so no one had ever talked to me about muscle mass and bone strength, and that, if I could gain 10 pounds of bone and muscle mass,
Mhm.
that I would live a lot longer and a lot healthier. It was all like, stay small, stay small. So
Mhm.
here I am, a tiny person who is suddenly having abdominal weight gain out of nowhere. I changed nothing. I was a marathon runner. I meticulously watched what I ate, other than the occasional splurge. Nothing had really changed. And I was suddenly having a belly where I never had one before.
Mhm.
And it was driving me crazy. And I was like doubling down at the gym, tripling down in caloric restriction. And it would work for a little while. I mean, the law of thermodynamics is there, but I couldn't maintain it. I couldn't maintain it and be a normal person.
And it's all
I'm
that like
getting,
right below the belly button, like
yeah,
right there.
yeah,
Yeah.
like, and my C-section scar is kind of like sucked in there. So like I was having this shelf form, all
Yeah.
cosmetic, really. I
Mhm.
was still a very healthy person otherwise.
Mhm.
But my patients were going through it. And these were women I knew. These were PhDs, these were doctors, these were, women erudite who were, telling me, look, Mary Claire, I'm not doing anything different. And they're shaking their tummies at me. And I'm like, okay, what's going on? So I called the PhD people in the nutrition department. We had a kick-ass nutrition department, actually. It was doing a ton of work on like protein and astronauts and the elderly. And I was getting so interested and involved in nutrition at that point. I'm like, what's happening in menopause? And so these PhDs were like, listen, there's something going on with inflammation. We know inflammation markers are ticking. I'm like, what? What? No, menopause is losing your periods and if you have flashes, what is the systemic inflammation and why is my cholesterol going up? And, so some of these lab markers for me were starting to rise in the background. My homocysteine was elevated. I'm like, wait a minute, what, so they send me down a rabbit hole of all this information on nutrition and menopause and inflammation. And then I'm pulling in all these other articles looking at body composition changes. Everything in medicine was BMI weight, BMI weight. No one at the time in my world was talking about body composition, that we're more than just a blob of fat rolling around, right? When we get on the scale, we are muscle, we are bone, we are fat, we are water, and learning how each of those contributes to our weight and the importance of that. So all of that swirling around in my head, what can we do about it? So I was, finding tons of information on quality of nutrition, on protein, on anti-inflammatory diet, on of course I'd heard of the Mediterranean diet, but I didn't know what that was. So I enrolled in the culinary medicine course. At the time, the guru I was following was at Tulane University, but now it's a whole national program, and learned it was like the idiot's guide for doctors for nutrition, and learned so much about quality of nutrition. Like we knew about kwashiorkor and scurvy and all these severe, malnutrition things, but not
Not the
about
basics.
good, basic, solid nutrition and how we get that into our bodies. And I mean, I was eating lean cuisines to try to stay thin, all this processed food.
All the sodium.
Oh, yeah. So I have this mental reset. So I just start sharing all the stuff I'm learning with my patients, with my girlfriends. So like, write this down. So that kind of was the seed for the Galveston diet. I developed this little program, just a few tips and tricks that kind of expanded, grew it with my patients and my friends, was going to Office Depot on 61st Street, making copies. This is in Galveston. So Lexi knows the reference, handing them out to whoever would. Then I started talking about it on social media. And I think it caught fire on social because one, I was talking about weight gain's not your fault,
Mhm.
especially in menopause. Number two, I was using really solid nutrition principles to address it. And then, people were like, you got to put a name to this. Da, da, da. Call it the Mary Claire diet. Call it, that just sounded kitschy. And in medicine, a
Mhm.
diet is is a nutrition plan. It's not a fad, right? We're like, what is your diet? Not are you on a diet?
Mhm.
And so I called it the Galveston diet because that's where I lived. And it just really exploded. So we turned it into an online course for 15 bucks. People could take it, and it just really grew a life of its own. We had hundreds of thousands of women enrolled in the course. It was all online. It was like videos, and it all started very very basic, me doing the graphics, me doing everything. And then it got so big, I was still working. I had to hire a team. I hired one person, one became two became five, and then on and on and on. So, and then I got approached to write a book about it. And that was my first bestseller, The Galveston Diet. Well, before the manuscript was even in, the conversation around nutrition and menopause had exploded to just menopause. And I was a sponge. I was learning so much information that was out there and had been out there for decades, but never put in front of us in our CMEs,
Mm.
and I was shocked. And so I started going to menopause, like conferences specific to menopause, and I would sit in the audience and cry because I realized I was a terrible menopause doctor, that I had harmed patients because I didn't know what I didn't know. I was saying things like, have a glass of wine if you don't want to have sex. Work out more, eat less if you're gaining weight. It's just hot flashes, honey. Take an SSRI. Oh, your mental health can't have anything to do with menopause. Uh, you know, we are ignoring women's health after reproduction ends. And it's a systemic thing. This is not me, Dr. Lexi or Dr. Mary Claire. This is a systemic failure for centuries of how we treat women in medicine and just shining a light on it. And it just kept growing on social. We have almost 7 million followers across our social channels. You know,
That's
the
amazing.
the new menopause was a number one bestseller the day it came out in the New York Times. Like I was just in the right place at the right time with a message that made sense. I spend hours every day researching, reading
Yeah.
everything. I have an alert, in my email every time the word menopause or perimenopause is mentioned in a research article. I read every abstract
Yeah.
every single day. I don't read every article, but I want to know what's happening in this world, and
Yeah.
there's some good stuff coming.
Yeah.
So, and it's just, for whatever reason, I've had the ability to share it to a large audience.
Yeah. And the vulnerability, I've told you before how much I love Brene Brown, and she talks about, being vulnerable and how to do that in the correct space and having a strong spine and being strong, but then being soft on the front a little bit. And I will be one to admit too, this is something I don't know a lot about. And when I have people approach me with these questions, they're like, "Oh, you're an OBGYN, you'll know the answer to this." And I'm like, let me educate you on what I was not educated about during my training. And this is a big, big part of it. Nutrition was a big part that we got maybe half a day in any bit of training that we had, like maybe
Yeah.
half a day. And I try to talk to that with patients about that too. And so in the aspect of being vulnerable in this space, because I'm going to ask a lot of questions that people will probably think she should probably know the answer to that. And now that I'm in my mid 40s, I am frightened about trying to find a provider for myself that will be able to understand what I understand, but also trying to be vulnerable when I go to the physician and say, I don't know the answers to these questions and I do need your help, because there's just things that get pushed off all the time. So, in the space of vulnerability, I have a couple of like random fun questions I ask my guests that are surrounding the space of OBGYN in a way. And I try to ask them to everybody because just what you said, we don't know what we don't know. And I think as providers, we oftentimes assume that our patients know certain things and we assume that other physicians know other things, but that's not always the case. And that's why the space of educating individuals from a safe place of information, I think, is so key. So are you ready for just like a couple of fun questions? Okay. All right. What does the abbreviation OBGYN stand for?
Oh, obstetrics and gynecology,
Man.
or obstetrician gynecologist. It depends
Yes.
on which way yeah.
Exactly, exactly. And this one always gets me because this is what I do and people still don't really know what I do. What does MFM stand for?
Maternal fetal medicine.
Yes. I always tell people that I say perinatology and they think I say paleontology. And I'm like,
Yeah.
okay, that's fair. That's fair. Another question.
Around the birth, perinatology. Yeah.
Exactly, exactly. And then next question. When is a delivery considered preterm?
Oh, premature. Wait. Okay. I haven't done obstetrics in
I
like
know. And they keep changing
since
definitions. So
2018. Okay. So before 36 weeks, or
36 weeks. So
37 weeks is
seven,
term.
37, exactly.
37 weeks
37,
is
0.
term. 37, 38, 39,
Yep.
40. Then
Hmm.
42 is post term.
Hmm.
And then premature is before
Yep.
37. Yeah.
Because we always ask patients to fill out all this paperwork, as they go to providers, and it's like, how many preterm births did you have? And it's like, well, help me define preterm so I know I can fill out my paperwork right? Okay, what is a normal fetal heart rate?
I'm always clocking around 140 is average. So like 120 to 155, or,
Yeah.
160 is when you cross over. So,
Yep. 110 to 160. Perfect, perfect. And how many weeks during a pregnancy should someone get that big anatomy ultrasound?
at how many weeks?
Hmm.
18 to
Yeah.
22, 20, or somewhere in there. Yeah.
Yeah, that's a big important one. And they're kind of trying to phase out of insurances covering nuchal translucencies now. So people are having to fight
Of
to
course they
get
are.
first
Of course
trimester
they are.
ultrasounds done. And then you have these poorly controlled diabetics that don't get a scan until 20 weeks and they have demises because their diabetes is so poorly controlled. So it's just
It's
like, oh,
insurance controlling healthcare is got to stop. I mean, we're just
it's
losing people, and they have no one is policing them. Like there's
mm-mm.
no, they're just willy-nilly doing what they want,
Mm-hmm.
and
Mm-hmm.
patients are suffering. It's
Yeah.
ridiculous.
There's so many complaints. I could get on such a soapbox about this, but like insulin, and I loved reading your book talking about insulin resistance as we age. And then in pregnancy, we have this huge insulin resistance that occurs as that placenta grows and grows and grows due to a hormone that comes from the placenta itself. And so when we give someone insulin during pregnancy, if you give them a certain amount, well, they're going to probably need a new amount a week from now, and then 2 weeks from now, 3 weeks from now. The insurance is like, no, no, you put in a prescription for 20 units. Therefore, I can't give her 22 units now or 24 units now. And they run out of insulin
I
all the time.
Amazing.
Yeah, like that shocks me. I
I,
guess nothing
I,
should shock
I,
us anymore, but
it's, I just, yeah, I, I stepped away from the third party model, and it's the best gift I've ever given myself and my patients, the freedom to practice medicine without being hamstrung by hospital administrators or by an insurance company. So,
100% agree. 100% agree. And I love that. All right, we have a couple more questions. What makes up amniotic fluid?
okay, fetal urine.
There you go. People always, patients are shocked when they're like, wait, that's my baby's pee. And you're like, yeah. So, and you and I both know because we've been splashed with it before, it is a little salty. Who should be offered Down syndrome screening in a pregnancy?
Everybody.
Yes. Yes, 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 yes. And the last question here, what is carrier screening?
Oh, carrier screening. So when you're a known carrier of a genetic
When someone hasn't
or
been screened. Like, you know how like when someone comes in and they're pregnant and they're like,
you're screening
okay,
to see if they're a carrier.
yeah,
Okay, so they
yeah,
have like they're Ashkenazi Jewish or
yes.
Cajun like me for
Yeah.
cystic fibrosis.
I think that the carrier screening gets mixed up with Down syndrome screening. So when we see people and they're like, oh yeah, I had my genetic screening, like genetics is a big word. And so I always tell people, I remember going to a talk in Vegas one time for March of Dimes, and there was a couple speaking about their child who was born with cystic fibrosis. They're like, we never knew, and this was such a shock. They were never offered carrier screening by anyone as far as their OB provider went, right? So, I mean, it's something that shouldn't be a shock to anybody. You should know if you're a carrier or not and have that offered to you. So, I've had people in their like fifth pregnancy, they're like, no one's ever talked to me about that. So, but it's the question of where's the space for that, right? As far as the OBGYN world and then crossing over and stuff. So, anyway, so um, I want to jump into, I was trying to start with what we call expanding our knowledge. So, like some kind of definitions and looking into things. And menopause definition is one of the things that I think people
Uh,
get so confused about because there's like, okay, the definition is like, and I loved reading your book. It's like this day is the day when this something things happen, right? But then you had this whole period before it, this whole perimenopausal period.
right.
So people, I think, as patients, get really concerned about trying to ask. I don't want to say people want to label, but people need to be able to identify with what they have so they can understand how to help themselves. So,
Right.
in defining menopause, how would you best frame the diagnosis for someone from a patient side and a provider side to help bridge that gap?
Um, I have so many problems. The medical definition of menopause is 1 year after the final menstrual period, and that's a natural period. So this is assuming no hysterectomy or,
Mhm,
ovaries being removed
mhm.
or zapped for chemotherapy or whatever. But, there's so many problems with that. What if she's had a hysterectomy? How do we define menopause? What if she has a Mirena IUD, which takes your periods away? What if she doesn't have regular periods, like in polycystic ovarian syndrome or other forms of hypothalamic suppression? What do we do in leap year, Lexi? Do we wait 366 days? I mean, it is a small symptom of a huge multi organ system failure. And
Mhm,
defining it by, just shows the narrow focus of women's health being tied to reproduction.
mhm.
And everything else is, well, the men, we'll just take the men's data, it's good enough. And women are dying because of it,
Yeah.
and suffering and quality of life and all the things. So what's happening is, and what most people don't understand, and honestly, when I think about it, I don't think I understood this either. That, I knew it, but like how contextually Women are born with their entire egg supply, right? Our eggs
It's
get
highest when they're like a
frozen.
fetus. That's crazy.
Fetus, yeah,
It's crazy.
in the fetus, at 5 months gestation, you have the most amount of
Yeah.
eggs. They've differentiated, they've split in meiosis, they've started, pulling apart in meiosis one, and they get frozen, okay, until they ovulate. And so, and that stock of eggs has to last them until they run out, until menopause. And so, in a healthy woman, so they stay in like a hybrid, sleeping state. We are losing them through the process of atresia, which is the survival of the fittest, we think. The evolutionary biologists are like, look, you want the healthiest eggs to ovulate so that we can propagate the human species. A lot of these eggs, there's something wonky happens in meiosis one, and they're never going to make it, or they're not going to make a healthy baby. So we lose through atresia. We're losing from 5 months gestation on. So by the time we're born, we're down to 1 to 2 million eggs at birth. Okay. And then we go through puberty, we start ovulating. All right. So by the time we're 30, we're down to about 10% of that egg supply. And by the time we're 40, we're down to roughly about 3%. Menopause represents the end of your egg supply. So we have a little egg, and then around the egg are follicular cells and granulosa cells. Okay. So this is this beautiful symphony that God or whoever created, in order for us to propagate the species. So ovulation begins in the brain. Menopause begins in the brain. Let me be clear. Okay. So the ovaries just sit around waiting to be told what to do. They do not, unless they're cancerous, act on their own. Okay. Or you have, some benign cyst or something. But in general, the ovaries function comes from signals from the brain. So we have the hypothalamus and the pituitary gland. Okay. Big names. So the hypothalamus is constantly sensing for estradiol, specifically in the blood. And when the estradiol levels drop off, as they do after ovulation, the signals from the brain go to the pituitary. I'm simplifying this, and say, hey, stimulate the ovaries. We need some more estrogen. So this LH and FSH signals go down, and they bind to those theca and granulosa cells around the egg and start pumping fluid around the egg that makes a cyst. It gets to a certain size, the cyst bursts, the eggs come out. Those granulosa cells are making estradiol, and the theca cells are making a little bit of androgens, tiny amount. And then once ovulation happens, then we have that surge of progesterone that lasts, 10, 12 days. What happens in perimenopause, which is the transition from, so if we look at the ovulatory cycle in a healthy woman, it looks like an EKG every month. It is this very predictable ebb and flow of hormones of LH, FSH, estradiol, and progesterone month after month after month. And for a healthy woman, on day 12, she's going to do X. On day 21, she's going to do Y. And it's very, very predictable and repeatable, unless she's pregnant, unless she's stressed, unless she's got some ovulatory dysfunction, usually coming from the brain due to diabetes or polycystic ovarian syndrome or whatever. But just for most women, this is very predictable. All of a sudden, when you reach a critical egg threshold level, and it's different for each of us, right? The signals coming from the brain don't work as well. The ovaries become resistant because we don't have enough cells to respond to those usual signals. So then the signals from the brain gets freaking out. Where's my estrogen? Where's my estrogen? I need my estrogen to function. Okay. This is well before your periods become irregular. This is years before. So then you get higher and higher signals coming from the brain to force the ovulations. So that kind of kickstarts the process until it just can't anymore. And then we have delayed ovulations, much higher estradiol levels, because the ovary is being sledgehammered by the brain to get the, estrogen out. So we get these big surges. So typically in a healthy woman, in premenopause, where our baseline estradiol levels are like 40 to 50, maybe. So that's kind of our baseline. And then at ovulation, it rises 100, 200, maybe 250. Okay. In perimenopause, when we do finally get to ovulate, because of this pounding coming from the brain, we'll see estrogen levels of 3, 4. I've seen 500. Okay. Incredible. And then it crashes down. The brain hates this. This is where we see the mental health changes. This is where we see the cognitive changes, the brain fog. Like the first sign most women have isn't a period disruption. It's, I don't feel like myself. I don't feel like myself. I can't put my finger on it. Nothing's changed in my environment. Certainly if, you're death in the family or, whatever, but like these women are coming to me saying, look, I had my stress managed. I had my life down. I built this life and I could run it. And all of a sudden I've lost my resilience. Now she might also have frozen shoulder or vaginal dryness or, joint pain, bone pain, all the other things, because it turns out estrogen receptors are everywhere in our body, the liver, the brain, the lungs, the kidneys, all of it gets affected when these, so in perimenopause, we call it the zone of chaos. So what used to look like an EKG literally looks like I threw spaghetti at the wall.
It's like AFib. It's just all over the place.
Just yeah. And then on the downward trend until you just flatline. And then you have almost undetectable estradiol, no progesterone, and your LH and FSH remain. Those stimulatory hormones never go down. Another interesting thing for your scientists in the audience, we have FSH receptors in other organs, not just the ovaries. So there's some great work being done right now looking at FSH independently, at least in animal models, is causing rises in cholesterol, is affecting the brain, it's not just the estradiol, it also is those stimulatory hormones.
Yeah. This is that really vulnerable time, I think, too, and I love how you call it this like phase of chaos, right? Because I'm thinking of things right now. Word finding comes to mind because it's like I want to say this word, but I can't remember exactly what it is. And like the inability to explain why you're feeling the way you're feeling, and then having this is the frustration I find as a patient, and I mean as a provider in general, is going to a physician with those symptoms whenever everything else is ruled out, right? It's not your heart, it's not
Right.
your
No,
thyroid, it's
yeah.
not, right? All those things.
I do a ton of blood work ruling
Yes.
out
Yes.
everything. I
So
don't
when
want to
all
miss.
those, no, but when all those things are ruled out, then you're left in this really, really extra spot of like, can someone please give me some flipping guidance on what I'm supposed to do to improve my memory, my ability to function, my stress levels when everything else is really taken care of? Because we oftentimes want to say, again, put a label on it. Well, I can't label it as menopause, so you're not menopausal, right? So I can't say that
You
that's
haven't
what you
gone a
are.
year without your period.
Right. But manage someone
So
with perimenopause and how, like, the knowledge of a patient and a provider for that space of like, what the absolute fudge am I supposed to do right now when I'm flopping around like a fish and there are so few people, at least I feel, that are there to help me. How can they really label it? And I feel like you said,
it's a diagnosis of exclusion.
exclusion. Yeah.
So we don't have a good blood test for perimenopause because again, the zone of chaos. We're great at diagnosing postmenopause. One-time blood test, boom, you're done. We know that's going to be your future forever. You are postmenopausal, and like menopause is one day, right? Everything after that, people are like, when am I going to be done with this? I'm like, your body is going to deal with the effects of the loss of estrogen and progesterone for the rest of your life. There is no getting around this. It is just, if you're ever confused, think about a man. We have to do it. We have to castrate him. It's so funny. We call it castration in a man, but when we remove a woman's ovaries, it doesn't have a name. Like when we castrate women for medical reasons, or when she's naturally castrated through menopause, we don't have a name for it. It's like,
That's true.
so when a man is castrated, he gets pamphlets, booklets, information like, here's what's happening, here's how to deal with it. Here's testosterone replacement, just like testosterone does not cause testicular cancer, right? But sometimes we take away the testosterone so that the testicular cancer doesn't grow. That's the same thing with ovarian cancer or breast cancer. So anyway, a lot of people are under the horrible misconception that somehow your natural estrogen is trying to kill you.
Yeah.
And it's not. It makes you healthier.
So then in the space of menopause versus those that have perimenopause, let's say,
Perimenopause, yeah.
I feel like that a lot of general OBGYNs, let's say, those that even focus more on GYN, because it's such a
They
large
weren't
field.
taught.
They weren't
They weren't
taught.
taught.
And if they were taught, it is you treat symptoms with menopause. We've never been taught in the past to treat perimenopausal symptoms.
So yes and no. So you think about it. 90% of us will have abnormal uterine bleeding.
So then, yeah.
So we're really good at working those patients up. Is it a
Mhm.
polyp? Is it a tumor? Is it a whatever? We treat those things if it is. If it's not, we're trying to give her birth control pills to control her cycles or an IUD or lots of great options. Okay.
Mhm.
So anecdotally, someone might be quasi treated for their perimenopause, might feel a million times better because they're giving them hormones to treat some of the symptoms of perimenopause, the most likely being abnormal uterine bleeding. So they're getting some kind of hormones given back to their body, even though it's ethinyl estradiol, not my favorite for this particular, instead of estradiol. This is one of my where economics and reality meet, what Mary Claire, if she was queen, would do. We don't have a contraceptive option, a dose high enough to inhibit ovulation of a non-synthetic hormone option. They do in Europe, and it's called Jolie.
Oh.
It is estradiol and progesterone in high enough doses to inhibit ovulation. Why don't we have this in the US? You know why? Because it's cheap. And
Would
no
you
one
think
would
that would
make
be
money
great,
off
right?
of it. Oral estradiol, a month supply is $1. $1. It is
Wow.
as cheap as dirt. It is cheaper than water. And big pharma is not going to invest in that. They're investing in alternatives to estrogen. They continue to demonize estradiol so they can make money on these. Now, I love having alternatives, but this is where economics, and no funding going into women's health after reproduction ends, meets where women are being forced to use something that probably isn't the best for them, but it is an okay option. I took birth control pills until 48, and I was very happy. I was treating polycystic ovarian syndrome. I didn't know that there may have been an option. I didn't understand the difference between
No.
ethinyl estradiol and estradiol. No one sat me down and explained the very, very different reactions the body would have. And you see time and time in the literature, estrogen is estrogen. It's not reasonable to think that these two very different chemicals that bind to the same receptors would act in the same way.
Right.
And have the same downstream, turns out ethinyl estradiol is a lot more inflammatory than just plain estradiol, which is anti-inflammatory. So, that would be my hope, is that we have non-inflammatory options to treat these women in perimenopause, to block ovulation, to help control these heavy periods.
And then that then opens the conversation of FDA approved, non-FDA approved, because I think that I live in the Scottsdale, Phoenix area, and there's a very, very common. I've had a lot of friends that are going to physicians, and then they come and ask me questions, but the physicians they're going to are maybe ex-family practice docs or ex-OBGYNs who decided they wanted to live in this space of hormones. And none of the ones that they told me they were going to have any true certifications in this space.
What's happened in menopause care, and in a lot of kind of in the hormone space in general, I've seen it in thyroid diseases. I've seen it in, a little bit in autoimmune, where we have doctors coming out of residencies, with this complete and utter lack of training. And it's not their fault, right? They're doing their best. They're busy. They're crazy running around, surgeries, babies, and oh my God, menopause. And so, and they were taught in this generation, the last 23 years now, that hormone therapy was dangerous for most women. And you want to use this, use everything else. And then if you have to give it to her, you want to use the smallest dose for the shortest time possible. ACOG has not updated their guidelines in 14 freaking years. They have not adopted the Menopause Society guidelines, which is that it's going to be safe and efficacious for the vast majority of patients. Have a conversation with her, let her decide. Here we have this absolutely desperate patient cohort, okay, who are having horrible quality of life, whatever. And then we have go to the far. So we have doctors who are untrained, well-meaning, but don't know what to do. Then we develop this cottage industry of hormone clinics that make the rules up, don't follow much evidence, and are using a lot of compounded and I think, again, in a space of trying to help people and doing the best, but not following any rigorous guidelines, or and when the guidelines aren't serving the patients or based on modern evidence, so us, the menopause in the middle is in the middle. Okay, we're not going to go to the far right and just cook a bunch of shit up in a compounding pharmacy and call it good enough, and a few patients will feel better, so yay, we win. Then we have on the left where they're just absolutely stalwart about these old ideas and not adopting the new research. And it's a bloodbath at those meetings, okay, when people start talking about hormone therapy. And then so we have us in the middle that are like, look, we can give good evidence-based care, use FDA-approved formulations for most patients, love having compounding as an option, but it's not our go-to. And these women are going to thrive. They don't have to go and spend zillions of dollars on untested, the worst option for a patient, that is absolutely costing them an arm and a leg. We can do some wonderful stuff here in the middle where we're evidence-based, following guidelines, giving our patients options. So, and I think that's what's happening in a lot of areas. with a big wellness culture is that there's some people who are untrained, don't know what they're doing and doing their best. And, a few patients feel better. I'm like, yay, look at me, we're winning. And I'm
Yeah.
making millions.
Yeah. Yeah. And then there's the fear too of starting hormone therapy because I think we see so much. My two big things that I hear in the media and from patients too, breast cancer and venous thromboemboli, right? So like some
Yeah.
kind of clot, and I have a history of breast cancer, a strong family history.
And there's a generation of clinicians who are telling patients, you can't have HRT if you're obese. Not true. You can't have HRT if you have a family history of a heart attack. What? It decreases the risk of cardiovascular disease and death from cardiovascular disease if you start early enough. Like there's so much misinformation out there.
Mhm.
You can't have it if you have any clotting factors or a history of this. I'm like, none of that is true. It is nuanced. You want to avoid oral estrogen if you're at high risk for clotting. Transdermal estrogen does not increase your clotting factors. You can use it. Vaginal estrogen should be in the water. Everyone should be on vaginal estrogen after the age of 50. Like 100% of patients, we would save so much suffering, so much misery, so much death and disease by just giving, proactively preventing GSM. Like this should be preventative. It's over the counter in certain countries, vaginal estrogen. Everybody's using it. It is
I
so
did
safe.
not know
Yeah.
that.
Yeah. Like it is so safe. It is so easy to use. And we could save Medicare billions by decreasing UTIs and urosepsis.
Yeah. Isn't it crazy though? Like you'd think
It's
people would want that. I mean, we
crazy.
want that clearly, but I,
If a man's penis shriveled up and was hurting and he lost all the tissue around his scrotum and his testicles just shriveled up and died and there was just an empty ball sack flopping in the breeze for the last 30 years of his life, it would be a national emergency. But yet we just accept it
yes,
as normal in females
yes,
and tell her
yeah.
to do some yoga and have some wine.
Mm-hmm. And
You
then
can't wellness your way out of
no,
this,
and then
you
she
know?
gets blamed for all the stuff going on, not the husband, because it's her. Oh goodness, don't get me started. I always tell people I wish I had my detachable penis when I go places. I could get hurt a little bit better. Like that's just part of my theory.
Wait,
Um,
Lexi, I had to ask if I could change my voice in my podcast to immense, like lower my
Stop it.
voice so that their doctors would listen. They won't listen to a woman, they will only listen to a man.
I just got chills down to my toes. Um, I- are you
There's a
serious?
reason that 85% of my followers on TikTok are female and 98% on Instagram are female.
I'm just like irritated. It's not even the word. Like part of me is like, and it's like for sterilization, right? Like for a guy to get snipped, let's say, it's like the world is ending. They tell all their friends, like, I can't believe I had to do this. I'm like, do you know how many women get sterilized all the time? And it's so much more invasive. Like,
It's surgery, major surgery.
yeah, the guys go in and are
So
out in like 15, 20 minutes and you get ice on your ball sack and that's that. Oh
yeah,
my gosh, the voice. You've got to be kidding me. Okay.
yeah, they wanted, she said, I think if you, put one of those voice filters on that you sounded like a man, my GP would be more likely to listen to you. And I think she's right. Where's the lie?
As I'm aging too, I'm like, how does one become a certified menopause specialist?
It's funny. The Menopause Society has a certification process, and I am
Yeah,
certified, but they handed you a book which was filled with scientific information, which was great.
yeah.
But a lot of it wasn't like, how do I take care of patients? Like, what's clinically relevant, And then you go take a test, which is a lot of statistical information, not
Okay.
really relevant to patient care. And
Yeah.
then you get certified. Okay.
Okay.
Well, they have a new president who I'm super excited about it.
Okay.
And her last name is Kenny, and she is an ass kicker. And she is
Nice.
developing a training program for clinical training of clinicians to learn how to do this rather than just like, here's a book, take a test, right?
Yeah.
And so they're launching it this year. They got a several $1 million anonymous grant and they've turned it into let's do a training program. And I
Awesome.
want to shout it from the rooftops. Is it going to be perfect? Probably not. Is it 100%? No, but like, goddamn, we're getting there, and they want to
Yeah.
reach 25,000 clinicians, and that's all specialties, not just OB-GYN. Menopause Society was not an OB-GYN spinoff. I want to be clear. This was mostly, when it
Mm-hmm.
first formed, it was like data scientists and PhDs and internists and cardiologists who just got interested in this.
Mm-hmm.
I did not have. When did you ever hear about Menopause Society? I didn't hear about it till about 3 years ago. I didn't even know they existed.
Same.
Yeah. So, and ACOG has their hands full right now with reproductive rights and everything. And I don't think that this should be an OBGYN issue. This should be every clinician who touches a female. We should mandate this training in all
Mm-hmm.
residency and education programs. Like, we disease differently than men.
Yeah.
We die differently than men. We have our quality of life is so much less than a man's at the end of our life in general. And that is begins in menopause. And like, how statins don't decrease our risk of heart attacks, primary heart attacks, but we hand out statins like candy to women. Like, where are the people screaming from the rooftops about this? Like,
Yeah.
we need to be looking at females and female health very differently. And then when you add in genetics to it, as far as ethnicity, we have different stratification there of how people
Mm-hmm.
disease and stuff. So,
Mm-hmm.
this really is more about precision medicine,
Yeah.
and I think we can take it at a larger scale.
Yeah. And in trying to develop the skills to kind of, again, advocate for ourselves as a patient, as a provider, how would you say that someone can best find a menopause expert? And
Yeah,
I like that
that's a
they have
great
the true
question.
certification. And I feel like most websites, when you find a provider, you can look and find out their certifications. But like that initial go-to and like, how do I make that next step to do this for myself as a patient? What's the best recommendation you have?
On our website at thepauselife.com, we have the Menopause Empowerment Guide. So it's a 14-page PDF. It's free, and it's a quick and dirty. If you go into resources, you sign up for it, we email it to you, and it's like how to find a doctor, websites, the Menopause Society website. The telemedicine companies, I really think, are doing a good job.
Mhm.
Um, are there, and they don't pay me to say any of this. And then we have questions to ask your doctors, labs to ask for, like how to like get the most out of this visit, how to educate yourself, what are the key things you need to know, how to call ahead, how to screen for a doctor to see if they're even doing menopause care. It's not reasonable to walk into your OB-GYN's office and expect, this wonderful OB-GYN who delivered your babies and, did your contraception and well-being care. Probably 85% chance they don't know enough to
Mhm.
really, and what I hope is they don't pretend to know enough like I used to do, and that they, at least now with everything on social and this whole wave of menopause, like, can
Mhm.
self-reflect and say, what, this isn't an area of practice that I have the time to really dive into, and it's really not fair to my patients to try to practice this type of medicine.
You said they can find it on the website and it's a download. It's in the book too? Is it in the book too?
Yeah, we talk about all
Yeah.
of it in the book and the new menopause. Yeah. And
Okay.
I'm also writing the new perimenopause right now.
Oh,
So,
stop
yeah,
it.
the manuscript is almost done. It's coming out in the spring.
Oh, I'm very excited about this.
Hmm. And
Oh.
we talk about the intersection of perimenopause and fertility,
Hmm. Hmm.
and so,
Yeah. Well, that's where a huge space for me kind of comes into is I do a lot of preconception consults across
mhm.
the US, right? Since I do telemedicine full time, which I think it's a great space. And people sometimes get nervous about telemedicine. They feel that if my doctor's on a camera as opposed to in person, they're not as good of a doctor because they don't have their own office. They're not like, following the man, if you will, like the big like
I
hospital thing.
I think that telemedicine is a great way as a stopgap until we can get
Hmm.
our, little trainees trained,
Hmm.
which isn't happening yet. And
No.
so, 8% of graduating residents last year felt competent, like felt like they were even close to like competent. So like we got 92% of people walking out of an OB-GYN residency program thinking I don't need to be doing menopause care because I don't know enough. So that's where we
Yeah.
are right now. So that's why I think, being able to scale menopause care through telemedicine, and again, not being paid for any of this,
Yeah.
is one of the ways.
Yeah, it's huge. And I think too, when we talked about too, like the transition going from you're kind of right. It goes from like starting your periods, right, to having kids, then perimenopause, and then you hit this menopause and postmenopausal time. That time when reproduction is ending, when you're not really sure when it ends, right? Because I care for patients in their 40s all the time, very commonly. So that question of when am I not going to be able to have kids anymore? And we all know the story of the patient who, oh, my doctor told me I'm close enough to menopause, I don't have to use birth control anymore, and they get pregnant,
Yeah,
right?
that never comes out of my mouth.
Right. No, it shouldn't, right? Like, I mean,
I
that's
say it's unlikely, but I cannot guarantee you. And depending on what state you're
exactly.
in, this is may not be a good idea if you're, if you have anything genetically wrong with your
Mm-hmm.
baby. So
Exactly. Exactly. And then as far as trying to have as much impact as we can, I know the resources that you have, and I'll include all of those with the podcast as well. The website you have, the books you have, the social media format you have. If there was something that you could say to a patient that thinks they're having perimenopausal symptoms, like if there were the top three things when they go
you
into the
probably
doctor's
are.
office, but
If
like,
you think you are, you probably are.
until someone can find the space of a true menopausal specialist, if you're at your primary care doctor, your OBGYN, is there anything in particular to help them refer you to someone or help them advocate for you within the healthcare system?
Advocate, like go in prepared, go in with the Menopause Society 2022 guidelines, and you can hand them over and say, feel free to educate your clinician, but you got 15 minutes. Don't do this during a well woman exam. This needs to be a problem visit. The well woman exam has an agenda. This is not part of the agenda. Okay. You're going to have to make a separate visit.
Mm-hmm.
Go in prepared and say, hey, I'd like to try this for 3 months. I'll let you know how I'm doing. Does that sound okay? You take the thought process off of this poor, busy clinician's lap and, just say, hey, I'm willing to I understand my risks. I understand my benefits. I want to try this. Can you write the prescription? And I'll let you know how I'm doing in 3 months. That usually works because you're
Mm-hmm.
taking, you know, they don't have to think and they're so busy and they're like, sure, you know, if they're not open to any of it, if they say something like, I don't believe in menopause or I don't believe in hormone therapy, it's not Santa Claus. And that they should admit before you even hit the door. So that is what calling ahead to say, does this practitioner,
Mm-hmm.
is the practitioner willing to discuss hormone therapy with me?
Mm-hmm. Absolutely. And then I think one of my last questions, and this was something that when I asked some people around the area here that they were curious about, was if hormone therapy is something that ends up being a good fit for someone,
Mm-hmm.
can they stay on it forever? Do they stay on it forever?
Yes.
How do they know when to get off of it? Are there labs to do? Like, how do you navigate
When
that
would you
really
get
weird
off your
space?
thyroid medication? When would you get off your other
Exactly.
hormones? Your insulin is a hormone. I mean, like you can stay on it as long as for you the benefits outweigh the risks.
Hmm.
And that may be for the rest of your life. If you develop a condition, if I develop a condition, Lexi develops a condition where it becomes a contraindication, that's a different story.
Hmm.
Okay. But as long as for you the benefits outweigh the risks, you can stay on it as long as you want.
I love that. That's fantastic. I'm so excited that you're doing this. I'm so excited I got to reconnect with you again too and visit with you and say hello when I was in Galveston last time, which was amazing, by the way. Is there anything else that we haven't covered that you feel like if you have the ear of kind of the audience of mine, which is probably a little bit different than your typical audience, those individuals who are exiting, maybe having children, curious if it's, because postmenopause, excuse me, menopause and the postpartum period have a lot of similar-esque symptoms given those really quick changes that we
Mm-hmm.
can have. And perimenopause obviously is not as quick of a change with that. But is there anything else that you would say for me as a provider or other providers listening, or even for a patient of anything extra of like, do this to best keep yourself safe moving forward?
Educate yourself, and realize this is not optional. 100% of us, if we are lucky to live long enough, will go through this and recognizing that this is a multi-organ system event, brain, bones, muscles. It's not bikini medicine. We have to stop thinking outside of the box of the breast, uterus, and ovaries and vagina. Those are important organs. I feel like gynecology does a great job with them, along with our breast surgeons. But women's health is more, we are not little men. We are not little men. And so, if you're going to take care of women after reproduction ends, you're going to have to step outside of the box and educate yourself.
Yeah, exactly. Thank you for taking the time today, Dr. Haver. I really appreciate it.
Oh, you're
Um,
so welcome.
and to those watching, thank you for joining and thank you for being part of the change and learning more and educating yourself so that you can best advocate to really navigate this complex system of healthcare that we have. You can find Dr. Mary Claire Haver on social media. You can also find her at her website, thepauselife.com. Please also take the time to check out her books, The Galveston Diet, as well as The New Menopause. Keep an eye out for her new book that is up and coming, The New Perimenopause. I'm Dr. Lexi, wishing you a happy and healthy journey through pregnancy, perimenopause, and menopause.